Should I say like I really like you know
At least we have a snow to drive in, just rain today, huh?
I mean I don't want to like
Yeah, here's this is the second half of the tendon lecture. So it's on the same PowerPoint as the last one. So here's more copies. They're going around. They're not stapled. We're having staple issues, I guess. The copier. So we're going to finish. We already covered flexor tendons. I hope you all had a good spring break, right? We already covered flexor tendons. We're going to cover extensor tendons. We have a, I don't remember where I put it. We have a team-based quiz, which it must be in my office somewhere, since so much time has happened since we went over this. We'll have a team-based quiz, which I have to go locate. And then we will cover arthritis. And we have to get through all this material because we have an exam next week. For those of you that don't remember, right? There was a lecture on industrial rehab, which I plan to put up on, I'll just post it, I'll record the lecture on the PowerPoint, and then I'll give you access, which I have not done that yet. I ended up catching a flu cold bug on my last day in Ireland and went down and out, so I'll get that done. But the material on industrial rehab is not on the exam, and I hadn't planned for it to be on the exam, so that doesn't impact us at all. So I hate to be kind of rushed, to just rush right back into it, but we have a lot to do, right? So we talked about the zones in flexor tendons, right? And we labeled them by certain areas on the hand and the palm and the forearm. And the zones for the extensor tendons are really easy to memorize. Because if you look at them, the odd numbers are at joints, right? So it's really easy to remember the zones of the extensor tendons, not quite so easy for flexors, because the odd numbers are at joints. So zone 1 at the DIP, and if you know where the odd number ones are, then you can figure out the rest of it without having to memorize anything, right? So if we know that a zone 3 injury is at the PIP joint, what would this also be called that we've learned about previously?
Is that A3 point?
No.
Oh.
This is the zone of extensor injury. Pulleys are on the volar side. We're on the extensor side. At the PIP, if we have an extensor tendon here at zone 3, what is that also called?
Is that the extensor hood?
It's at the extensor hood, but specifically what do we call that little section?
central slip.
Central slip. Yup. Yes. And a central slip injury leads to what other deformity?
Boutonniere.
Boutonniere.
Session number.
If we have a zone 1 injury, what is that also called? Terminal tendon, but what do we call that injury? Mallet finger, and that leads to Swan Neck. So we're going to go through these fairly quickly because we've already learned a lot of this information, right? And yay, you remember it from a few weeks ago, right? Okay, so here's the zones of injury, really easy to remember with the extensor tendons because they're at the joints. And if you know where the joints are, then you know what the zones are in between. So just like the flexor tendons, it's more desirable to injure more proximal, less desirable, harder to get a good outcome more distal because the anatomy is so much more complex than if you have a more proximal injury. So there's some differences between extensor tendon repairs and flexor tendon repairs. The flexor tendons have a different shape than the extensor tendons. Remember how I talked about before that the extensor tendons, you can kind of see them on the back of your hand, and they're thinner and broader to resemble more like a linguine type structure than more round. So they don't have like coarse sutures. You can't put a lot of suture strands like you can in a flexor versus an extensor. So they're thinner, broader, flatter, and they're only 50% as strong as those flexor tendons. So the repair cannot be as strong as the flexor tendon. So that's a difference. This says, in the literature, it talks about that they're more prone to rupture than flexor tendon repairs, but I don't know that that's what I've seen in clinical practice. I think I've seen more flexor tendon repair ruptures than extensor, but variability. A big thing though is, remember we talked about that gap that can occur with tendon repair. A gap can occur if there's too much force in the tendon, and then later it may rupture. The problem with a gap in the extensor tendon, so if I cut my extensor tendon, God forbid, here, and a gap was created, I would no longer be able to extend my finger all the way because my tendon is now longer than it used to be. Do you see what I'm saying here? So if I lengthened my tendon, if I did full excursion, I would no longer be able to extend it the full way because my tendon lengthened, stretched out, got longer. So a gap, every 2 millimeters of gap, which is teeny weeny, right? 2 millimeters equals a 40-degree extension lag, which is huge for function, right? Try to get something out of your pocket with a 40-degree extension lag. Or, you know, it's very huge impact in function. The extensor tendons are also really superficial, so you can cut them very easily because they're right under the skin. You don't have that palmar fascia like you do on your palmar side to protect them. And another thing is when you have a tendon repair at P1, what is P1? What am I referring to when I call P1? Proximal phalanx. P1, P2, P3, right? Proximal phalanx has the largest tendon to bone interface, which means the tendon is right along the bone. So that makes it really likely to get adhesions, so the tendon to get stuck to the bone. Remember that extrinsic healing that we talked about, that we don't like, because what does extrinsic healing prevent us from doing?
Having
Gliding. And if we can't glide, we lose active or passive range of motion? Active. So we need tendon gliding. So if you have a tendon rupture and laceration, whichever, at P1, really hard to get good gliding because it's so close to the bone. Extrinsic healing occurs. Okay, another thing is that when you compare the extensors to the flexors have lot more excursion than the extensors. Meaning they have a lot more glide to create function. And they're naturally weaker. So if you think about it, everything we do in our life is function is flexion. We grip things, we grab things, we hold things. There's not much we do this way, right? We wave, but that's a non-resistive activity, right? There isn't much we do this way. So our flexors are naturally stronger than our extensors. So when we take these naturally weak extensors that have a lower amount of tendon glide, that have a naturally weaker repair with a large bone interface at P1 and right under the skin elsewhere. Do you see where there can be some problems with return to function? This naturally weaker tendon is already weaker, and then we immobilize it, and it gets weaker, and then we want it to extend all the way. So the biggest problem with extensor tendon repairs is lag. That's your biggest thing. And you lag either because you can't tendon glide, you can't glide through, it's stuck to bone on one side or skin on the other. You created a gap because you didn't follow the precautions in the first end and you got a lag. Or it's just weaker. So with extensor tendons, we're constantly battling a lag. So if you have a lag with your extensor tendon repair, you have to address it right away. It's not something that will just get better over time. You have to address the lag right away or you're screwed, basically. I mean, you really have to get it going right away. You can't wait on that. You've got to get on it. So we already know about this mallet finger zone 1, right? The terminal tendon gets cut, yeah.
What did you say the lag is functional?
Droopy.
Oh, okay.
It could either be at the MP, it would look like this. At the PIP, it would look like this. Same thing where I can push it back up because it has good passive motion, but I let go and it droops back
So
down.
a lag is basically a limit in active.
A limit in active range of motion, a limit in tendon glide, or there's a gapping. Same thing with the finger in flexion. Remember, I could push it down and I let go and it pops back up. That's limitation in tendon glide. With extensor tendons, it's a lag. So it either looks like this or it looks like this. I can straighten it back up passively. I let go, droops back down. That's an extensor lag for extensor tendons. For flexors, it's a limitation in tendon glide. It's the same thing, limits in tendon glide, but they call it a lag for extensors. But it's really the same thing happening. So we already learned about these zone 1 mallet finger injuries. The terminal tendon gets cut, the tip gets droopy, right? We splint it continuously, never let it drop, right? For 10 weeks, 6 to 10 weeks, it depends on how they're doing. Sometimes they do have to do surgical intervention, which they would pin the area. If it's not treated, you develop a swan neck deformity. Something else just to note too, you don't want to place the DIP joint in huge hyperextension, but you do want some hyperextension. If you put it in so much hyperextension that there's blanching occurring, what causes blanching? Lack of blood. So what do you think's happening to your tendon underneath? Is that also blanching? Yeah. So if you have a lack of blood, how will that improve healing? Won't. So if you put it in too much hyperextension, it will not heal, and you'll get, avascular necrosis because it's too much hyperextension. But you want some hyperextension. And when I was in Ireland, I didn't actually see this being used, but Courtney Hewson, one of her clinical placements was in a hand clinic, and they had this wood splinting material, which I don't know how friendly it is to use. You have to have a special oven to heat it, to then mold it. And she said that you could then reheat it in the special oven. I don't know how costly the special oven is, or I didn't see the special oven. But she gave me a brochure, but I brought the brochure home with all my other stuff, so I'll bring that. But I wanted to, since we were talking about this would be a splint that you could use for mallet finger. I use Quickcasting, which if you had me in 4720, we did Quickcast. Remember the tape material that you heat with the heat gun and you wrap it around, and that's what I use for all of my mallet fingers. But I'll pass this around. I don't know how well the strapping would stick to this, because you'd have to secure this on for a mallet finger, but you can see what it's like. So it's made of wood. So you've already seen these pictures before. This is the mallet finger. Tendon comes apart. Sometimes it takes bone with it. And then what is that called? Bony mallet. Bony mallet, okay? And then you approximate the two ends back together, which is why we never let it drop, right? And if you let it drop, your time clock starts over, which is why you have to really make sure you hold it securely, educate your patient, because they may have gone 4 weeks, and then you're in the clinic and you let it drop, and then they gotta start over, right? So these are situations. With tendon repairs, there are things that you can do that cause harm, so you really have to be careful with that. And then if it doesn't heal correctly, you can have potential for swan neck deformity. Another thing that you might have to worry about is if they're already developing a swan neck, you might need to splint the PIP in slight flexion. And by splinting the PIP in slight flexion, that brings those lateral bands back down to the side where they're supposed to be, and instead of letting them rest up on top, causing the hyperextension of the PIP. Do you guys feel like you already forgot everything from the first half of this? I'm seeing like a lot of like scared faces. It's in there somewhere. You just gotta review the material, right? Review the material, it'll all come back. Aubrey, did you have a question?
Can you just say that last thing about bringing the what?
Yeah, so when you splint, so if they're already starting to develop a swan neck, and sometimes that can happen fairly quickly in people that are loosey-gooseys, like those hyper lax people that hyperextend at the elbow and the knee, you know. Sometimes they can develop it really quick. So you splint the PIP in slight flexion along with the mallet finger. And what that does is it brings those lateral bands back down along the sides of the finger. Yeah.
Is there something here too with the mallet finger that gets like stretched?
Remember you have ligament structure that keeps it from hyperextending. That can get overstretched.
So is that helps you correct it when you put it in flexion?
It could help tighten it back down. Because remember, soft tissue lengthens and shortens in response to the need. So if you don't let that go into that hyperextension, that might tighten back down. Kind of like putting something in a cast. This is going to tighten up. And this just shows lots of options for splinting mallet fingers. These are called stack splints, which some doctors use. You just purchase them off the shelf. They don't hold the finger typically in enough hyperextension. You want a little bit of hyperextension, not too much because of avascular necrosis. You don't want blanching. But these don't really hold the finger in any hyperextension, and when you take that baby off, your end result is you'll have a lag. So I don't like using those. And if you think about it, already remember the extensor tendons are at a, what do you call it? Look, they're behind the 8 ball. They have a disadvantage, yeah, because they're already weaker, right, than the flexors. At this area at the DIP, the extensor tendon is 3 times weaker than the flexor. Then you put it in this splint for 6 to 10 weeks. You get a little scar adhesions, little extrinsic healing to get it stuck, and you got a mess. Like, these are the worst injuries for the patient to treat. Yeah.
You don't really have to elaborate, but do you use a weaning program with your mallet fingers?
That's their research project for, so what I do is I don't use any of these splints. Do you have that wooden splint?
Yeah, right here.
Can I just show you something real quick? Because it kind of fits just the wrong way for my finger for this example. So if I put this on my finger, and because this comes down almost to my PIP, if I flex here, it pushes, now the splint, there's a gap in there. which is one reason why I don't like splints, is because when you use your hands forcefully, and the PIP can flex a lot, right? When you use your hands forcefully and flex it, I'm just pushing that baby right off my finger, right? So what that does is you can get your patient in some nice hyperextension in the splint, and they use their hand, and it slides, and then pretty soon your finger's resting in slight flexion, and you get a bad outcome.
So is that why you use the casting tape, because it's more giving to that?
It's not more giving, it holds that, it's circumferential, so it doesn't let it slide off. It holds that sucker on there. It's not going anywhere.
What is the cat, it's like a tape, because we didn't get to play with that.
Let me go grab some. I got some. Hold on.
I'm like, truth about the
So that's really,
It's a way to
then you can say like, on this.
It was right, the light
So this is Quickcast material. It's really cheap. They stopped making it for a while because they weren't making money on it. And then all the therapists were like, do you have any extra boxes of Quickcast at your clinic? Can I buy a box from you? You know, like it was crazy. Like this was it was like the black market Quickcast. Because you couldn't find it anywhere. Everyone was like, do you have any extra boxes of Quickcast I can buy from you? Because they stopped making it because it wasn't profitable. And then after protests from the therapists, like, please bring back, charge double, I don't care, like it's the best product. And we tried using other things, it did not work as well. So Quickcast, this is Quickcast 2, you can buy it through Patterson Medical or through North Coast. It's like $3 a box, or maybe it's $5. It's cheap, 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 cheap. So all you do is you take a little piece of this, and it's called Quickcast for a reason, because you gotta be quick with it. Super quick. The working time, like you can't have a conversation while you're doing this. You gotta pay attention and do it quick. Heat with your heat gun, and it gets like a little see-through as you heat it. See how it's getting flatter and it gets a little see-through. And I'm gonna quick cast. Oh, I got your pretty markings. Shivani. And then you just wrap this around. I don't know, it's magic stuff, but. And then I would put her PIP in flexion and put her in a little bit of hyperextension and hold it on there. And then I would put one thin layer, and then I would do another. I can even like do little things like, say she's not very active, and I don't want to put a bunch of stuff on her, and she has teeny weeny fingers, and her skin kind of has poor integrity. She has Raynaud's or something like that. I can even cut a little piece like this and just put it around the volar side so she can have airflow on the dorsal. And this thing, oh, it did come off, but usually it does not come off. And then, but we want it to come off because I don't want to have to cut it off. See? But that works great. Works fabulous. And that's what I use with all of my Mallet Fingers. Way better than splinting. You do have to have the patients come in weekly for a cast change because their skin will get irritated. But I don't like any of these options. And then what I'll do is if I need to make a splint to put the PIP in slight flexion, I'll make a splint and put it in slight flexion. And then the weaning protocol is I have the patients wear that cast with weekly cast changes until the doctor says, okay, you can take off the cast. Okay? And apparently there's no literature that tells you what to do next. But what I have found to be the most effective, because I already have a naturally weak extensor, 3 times weaker than the flexor. If I just take that off, they're going to get a droopy tip. It doesn't stand a chance, right? So I make them a splint that they wear at night that's long. I make them a short one like that wooden one, but I don't roll the edges, and I only go halfway up, and I strap it on with Velcro. And I have them wear that during the day on a weaning schedule. I'll start just having them take it off for an hour, put it back on. Take it off for an hour, put it back on. If they notice any drooping, back on early. And then if they're doing okay, the next day I might have them take it off 2 hours, back on for an hour. Off 2 hours, back on for an hour, and always wearing it at night. And if they notice any drooping, put it back on early. And I slowly wean it by day. And continue to wear it at night for maybe another month. So that's what I do. Never force it to bend. Patients are always worried, well, it's stiff, it's not bending. It will bend. It has a naturally stronger flexor, 3 times stronger than the extensor. It will bend. What we want to keep is the up. We want to keep the straight. Okay. Any questions about mallets? Mallets are common. Mallets are mistreated. Mallets are tough to get a good outcome. Even if you do all the right things, it's not unheard of to get a 15 to 30 degree lag anyway. So it's hard to get a really good outcome with a mallet. So when we were working to set up the Calvin Clinic, one of the speech therapy faculty, I go to a meeting and she's in there with one of these stack splints on. I'm like, what happened to your finger? She's like, oh, I ruptured that tendon. I went to the doctor and they put one of these stack splints on. I'm like, no. Come down here to campus, and I made her a Quickcast. She came in for weekly cast changes, but right at the time where she was ready to be weaned, to start the weaning process, she did a study abroad trip for 3 weeks to China with students. So I couldn't monitor her. And she's hauling luggage, you know, for any of you that went, none of you went on the Ireland trip because you wouldn't be here otherwise, but it's a lot of hauling your stuff, not really paying so much attention to what's happening with your droopy finger, and she didn't have a good outcome. She still has a droopy finger. So we tried. Okay, so again, zone 3, central slip. Right? You do the same thing. You split in continuous extension. You approximate the ends, right? You can have surgical option if the conservative option fails. And even when you start moving, it's very common to use a short arc protocol to get people moving. So by that, I mean, we do that continuous splinting, just like with the mallet finger. When you get to the point where the doctor says, okay, we're going to start to wean you from the splint, we just do it differently. we don't just take it away. At this point, 2 times weaker than the flexors. We do it, and maybe, maybe this would be a better idea for the mallets, is to do a short arc protocol. We keep you in the splint. We make an exercise splint, which allows you to flex 30 degrees. You take the splint off, you exercise to this fabricated amount of 30 degrees, and all the way up and down, and all the way up and down, and all the way up 10 times, put the splint back on. Next week, we increase you to 40 degrees. And you go down to 40 degrees and back up, down to 40 and back up, put the splint back on. And so on. So you get to like 60, and then you take the splint away. Still splint at night, again, because that naturally weaker extensor tendon. Okay? Here's just the picture which you've been shown before, where that tendon comes apart. Any questions about mallet or central slips? No? Okay. So the next, we're going to talk about zone 5 and zone 6. We know zone 5 would be at the MP area, right? Zone 6 would be in the hand. These patients typically get a pretty good outcome. There's 2 different ways to treat them. One way, well actually there's 3 different ways to treat them. One way would be just to put them in an MP block splint, which is you would put a volar-based splint on and block the MPs in full extension and allow them to do IP motion, but this is being held in full extension for 3 weeks, 3 to 4 weeks. Then remember that day where the tendon gets stronger, day 21, you take the splint off and you start to let them start doing gentle motion. That's one way of doing it. Another way is this dynamic protocol, where you use the dynamic splint. And this doesn't really fit me appropriately, but you put them in a dynamic splint. These cuffs, which is the same kind of splint you would use for radial nerve palsy, right? These substitute for the extensor tendons, okay? These little things here block, don't let you bend too far, okay? So with this, you let the patient flex their IPs, and they can flex their MPs just to the point where these blocks hit it, and it only allows so much motion, and they relax, and the rubber bands pull their fingers back. The goal is to get tendon gliding without too much force to create gap. So when I first started working as a hand therapist, this was the new rave, and all the doctors were doing this. I would say now the trend has there are some doctors that do this, but the trend has kind of gotten away from this because it's just so complicated, right? It's a lot of work. What if this gets loose and they're allowed to bend too far? Then we might get a gap, which then creates 40-degree extension leg, so I think the trend these days is to get away from this and just use the static. And in trying to find a better way to allow tendon glide, but not too much tendon glide, is they've created the yoke splint, or they call it, oh my gosh, help me guys.
Relative motions.
Relative motion splinting, where they allow some motion, but the splinting acts as a block. So you can simulate it very easily with a pen. So say I cut my extensor tendon in zone 5 of my long finger. If I make a splint that holds that finger up, or in greater extension, I can flex my finger, but that will never bend too much. Do you see what I'm saying? So you make a splint that's like brass knuckles, they kind of look like. You know what brass knuckles from boxing look like? or they're not really for boxing, they're for like fighting. So hopefully none of you know what they look like. But you just weave it with holes so the fingers can fit in, but the tendon that was lacerated is in an elevated position. You do the same thing if you can't get a finger to flex following tendon laceration on the flexor side and they have poor glide. You would put it the opposite way and you would try to block it so that it can hold the MP in more extension to get more force for the flexor. So you do the same kind of idea, relative motion splinting, to gain motion for flexion. But for these extensor protocols, it's holding it more in a slap, is what it's doing. Okay? So relative motion splinting, also called yolk, like the yolk of an egg, is how you would look it up. But again, our goal is to always get glide. Usually at 3.5 weeks, you allow full finger flexion because you're past that 21-day mark, which we already learned about. At 4.5 weeks, we'll stop the splint. If they can't get flexion, you can do dynamic flexion at 6 weeks. And PREs, someone asked me, what is PRE? Progressive Resistive Exercise. It's an abbreviation for strengthening. 8 weeks. 8 weeks is typical for strengthening or PREs for most diagnoses in the upper quadrant. And remember, we include all the fingers because we have to young Shura. So we have to, no matter if the middle finger only gets cut, we have to include them all. If there's a zone 6 injury to, remember we have these additional tendons. We have the extensor indicis proprius, which extends our index. Then we have the minimi that extends the small finger. If you cut those only and not the other tendons, then you can just split that finger. But it's very, I think I've seen one time that ever happened. Usually if you're going through, you get them both. Okay. Tenolysis, I think I might have mentioned when we talked about flexor tendons, but tenolysis is the save. I'm stuck in scar, I have good passive motion, but I have a gliding issue. They go in, they clear off all the scar tissue that's keeping the tendon from gliding. You start therapy right away because they didn't cut the tendon, so you start moving, there's no mobilization period, you start moving right away. You want to avoid strengthening because you could have a tendon rupture as a side effect that you could have. That's because they're messing with the tendon and it could be weaker from the surgery. So you want to avoid resistance for a period of time. But usually these patients always gain active motion after. And I don't tell my patients about this option because they'll just say, hey, I'm not doing all this. I'm just going to have a tenolysis later on and I'll get my finger moving. You could get an infection with it. You could have nerve laceration with it, blood supply laceration because they're cleaning out scar. So it's not an easy save, but it is something that's an option if you get a poor outcome. They're not going to do it for 20 degrees loss of motion, but if you have significant functional loss, it's an option. Tenolysis of either the extensors or the flexors, done for both. Okay, and these are the complication rates with things that could happen: infection, tendon rupture. CRPS is that complex regional pain syndrome, and then hematoma development, which is a formation of blood. And then I just put some other things, some activity ideas, kind of what to do. These are non-functional, non-occupational based activities that you could do in the clinic to try to get motion. If you have a problem with just PIP flexion, doing things like, occupational based activities aren't going to be specific enough to get that motion. Blocking exercises, a rote exercise are what you need to do. You'll be doing your patient a disservice, and I know I'm probably would be banned by many of the other faculty in my department, by doing an occupational-based intervention, because that is not what this patient needs. They need focused motion to the single joint, and there's no function that does that in an efficient way, right? They need a roped exercise to gain tendon glide at that specific tendon. They need a non-occupational based activity. Of course, we encourage them using their hand for occupational based activities all day at home. These patients are outpatient. They're working, they're doing their own laundry, they're cleaning their own home, they're independent with ADL. It may take them longer time, they may have to do it differently because of their injured hand, but we're not working on those specific things with these patients. Okay? I went to, we had one of the Jan Davis lectures was, or one of the Barbara Rutter colloquium lectures was Jan Davis, and she came in and she did a wonderful lecture, and several people after the talk came up to me and said, well, there's nothing occupational based about what you do in hand therapy. I never see anyone doing, and to a point that's true, but if you were to hear me talking with my patient, everything that they're doing at home is occupational based. I'm giving them things at home to do to help support what we're doing in the clinic, but I'm using my valuable clinical time that they maybe only have 6 visits. I have 20 minutes of hands-on time with them to do something to focus on what they truly need. And then I give them suggestions of occupational-based things to do at home. So if you go into hand therapy, don't let anyone criticize you for not doing occupational-based activities. You're doing the right thing. You're promoting them to do occupational-based activities at home. Now it's different if someone has complex regional pain syndrome and they're not using their hand for functional tasks at all. Occupational-based activities would be a great way for them to get started, especially that focus on stress loading, like we've talked about in the past, scrubbing and carry. That would be a great way, but you have to use your clinical judgment in your own brain of when to do what, right? So don't let anyone criticize you. Okay, so here's a few things. These are not occupational based. Well, you could say beading could be a little bit occupational based, but it's really not. I don't know that many people get that much individual pleasure out of beading. I know. But crunching paper. If you just have a patient take a piece of paper and crunch it, it's a great activity to get them to do a functional activity, because sometimes you get a bad letter and you want to crunch it up. Well, now they all come in emails, right? But this is a great way to make the fingers work as a team, because patients get in the habit of keeping the finger out and try to avoid using it. You can grade it. If you can find an old telephone book in a corner, the telephone book paper is very thin, where this is thicker. I like magazines because they're somewhere in the middle. So every clinic has old expired magazines that they're going to throw out anyway or put them in the recycle bin. I always have a stack, and that's one of the first activities. So following tendon repair, I do the whole baby chick routine. Remember we talked about that? Once the patient can do that pretty well and I'm doing tendon glides, I start having crunching thin paper, not this thick. And that is a non-resistive activity where the fingers are working. If you just put something in the hand, it sometimes makes a patient move better than this open chain activity of moving in space, right? Just put something in their hand. Whether it's a dowel, right, a china ball, a bead, or something, sometimes just having that proprioceptive input into their palm helps them move better. A juxtasizer is one of those things that they have to hold and move the little bead around the little bent wire, if you've seen those before. Do you know what I'm talking about? We have one in the hand clinic. It's called a juxtasizer. So, if you want to put what you're doing, and you know it's juxtasizer. Isotonics typically, I know I put putty here. You could do putty, foam pickup, hand helper, which is a gripper, Digiflex. even just taking a sponge and putting it in a bucket of water and having the patient squeeze the water out. Free weights, clothespins, upper body exercisers, supination pronation bar, or even just a hammer for Supin Pro. And then anything aerobic to get their overall body circulation up always helps people improve. And I think this is our last. So I need to go find my team-based quiz. I know I've already made copies, but I actually didn't think about it until just now. So let's take a break. I'll go get your team-based quiz, and we'll do that. And this Quickcast is up here if you guys want to take a look at it.